of revised lockdown restrictions last night were made in anticipation of mass social and religious gatherings over the Easter weekend. The restrictions are meant to curb a rise in infections of the coronavirus during the current pandemic. But to what degree will the amended lockdown restrictions have in safeguarding the public during one of the country's busiest periods? To talk to us about this, an infectious diseases specialist, Dr. David Stead from the Frere Hospital in the Eastern Cape. A very good morning to you, Dr. Stead. How far will these new restrictions go in slowing down the number of infections?
Good morning, Desiree, and to the viewers. I mean, he's actually relaxed the numbers for gatherings in religious gatherings and other to 250 from 100 indoors and 500 outdoors. So that's rather than reducing infections, that is a potential risk. I guess it's as it has been all along, has been a balancing act between needing to consider, people's spiritual well-being and need to gather. I imagine, some large churches with large venues have been very restricted by the 100 cap, and some can probably, safely within 50% occupancy can reasonably safely have 250 indoors as long as they're following precautions. I think that's the key thing, and so there, it seems that there's some compromise to try and allow gatherings. We were under hard lockdown last Easter. Obviously, it's an important time in religious calendars, and so I imagine that's a bit of compromise for gatherings. I think the key thing really, we've seen that obviously these restrictions can't be policed effectively. The number of churches, we're based in the Eastern Cape, many in rural areas, they're far from sites of any police service, or far beyond capacity to actually be restricted to be monitored by government or municipalities. So it really comes down to individuals taking responsibility, individual church leaders being responsible in their gatherings, following protocols, and I think that's really key, that people remain vigilant and take individual responsibility, try and limit gatherings, especially indoor gatherings. We know those are high risk for transmission, and that where there's better ventilation, that reduces transmission. So where possible, gather outdoors if gatherings are needed, and really just limit attendance as far as possible.
You talk about gatherings, but alcohol becomes a major concern as well during Easter weekends. Will the restrictions announced by the President last night make much of a difference?
Yeah, I'm concerned about on-site alcohol consumption. So as from the hospital perspective, alcohol is a double whammy. There's no doubt that when people are drinking, when they get drunk, they're not social distancing, and their masks are off, and I don't think pubs, shebeens, clubs, that's probably the places where social distancing happens the least. I think restaurants do reasonably well where people are seated, that they can have some control, but obviously people at a bar, just the sort of makeup of shebeens tends to be quite casual and a lot of crowding. So that's, the fact that on-site consumption is still allowed, that is a concern, definitely from just what we've seen in the areas in the Eastern Cape. Heavy attendance at shebeens, overflowing into the streets. We saw that before the second wave, and that is a concern. The restriction of alcohol sales, off-site consumption during Easter. I think people are getting quite good at anticipating restricted alcohol sales and stocking up. We've been given some warning. So whether, it's possible that might, limit some excess alcohol consumption over the Easter weekend if people haven't bought enough before Easter. But I'm not sure how much that's going to really limit the off-site alcohol consumption. So what I was saying is, in terms of the double whammy, is that we also, the hospital's obviously burdened by all the trauma that's clearly alcohol related. Obviously Easter is usually a time of high road traffic accidents, and that fills up ICUs with a lot of trauma as well as assault that goes on with alcohol. So we are concerned that it's likely that alcohol is going to be flowing fairly freely during Easter, and that both we may see a couple of weeks later COVID numbers increasing because of that, but we will also quite likely see the immediate effects of alcohol-related trauma that brings a big burden on our hospitals.
Since the lockdown and the pandemic, set upon us, we've seen lots and lots of research and studies coming up. Just from an infectious disease point of view, has there been any link made in terms of alcohol and the level of infections?
I'm not sure about the direct impact. I mean, it's challenging because all of these restrictions have come in, it's seldom there's been one intervention. I mean, it'd be nice to look back and if you could point to South Africa's numbers and point to a specific, alcohol restriction and impact on transmission. There's so many different factors and invariably we've, had other interventions at the same time, restricting gatherings, restricting interprovincial travel. So I'm not aware of a sort of a conclusive direct link with alcohol. I think it's rather that we're aware that people's behavior and definitely what the impression that we had, so people are probably familiar with the term super spreader events, where you have an event where large numbers of people gathering without masks, close contact, especially indoors, that can really cause a rapid spike in numbers, and before this, we probably at a similar level now as we were in sort of September plus minus last year, with low levels of infection. We'd like to see zero infections. Unfortunately, the COVID's it's still there, it's still grumbling in the community. What we saw in about October was we had the October, November, the matric raves, which definitely were linked to a significant number of COVID cases, and definitely in the Eastern Cape we had a number of cases of student parties and clubs that were clearly infringing numbers and large numbers of people gathering indoors without masks and partying. And I think that definitely caused was the beginning of our. It's very likely that seemed to cause the beginning of our second wave. So I think alcohol consumption, especially excess alcohol consumption, often goes with gatherings with masks off, especially when in an indoor space. That it's very likely that links to increases in numbers. I know the alcohol industry will argue that that's sort of assumptions, but it's a difficult thing to prove conclusively with science.
You operate in a province where, at the height of infections, it was always pointed out as a hotspot. Just give us a sense of your work experience and how you've interacted with this story since the last year.
It's been a very challenging year, and I mean, at least we do feel a bit better prepared. That we've had two waves of experience to understand how to manage COVID, but it's been extremely intense, and we are an under-resourced province. So we're an under-resourced province that was then hit very hard with the first wave and the second wave. The first wave hit our staff very hard. We had massive numbers of staff infections and staff absenteeism, and even some staff succumbing to COVID, which is very traumatic. So our staff have taken a lot of strain. Some of them are still haven't fully recovered from COVID. And so it's been a very, very heavy year. I think we would be very grateful if that was it and there wasn't a third wave. The predictions are that a third wave is more likely than not. Quite what a third wave will look like. We hope it may be less intense than wave 1 and 2, but COVID has taught us that it's quite unpredictable. Yeah. Its ability to mutate and escape immunity to some degree is a concern. So we definitely concerned that we could still be vulnerable to subsequent waves. I think in terms of resources, staffing has been our greatest challenge. We've had ventilators donated, we've had equipment, some of it from the Solidarity Fund, some of it's come in a bit late, but we're fairly well equipped now. But actually, the greatest challenge for staffing our COVID for providing a COVID service is actually staffing. And you're probably aware that there's been health budget cuts. we've challenges with keeping on contract staff that were brought on for COVID. I think they've just been extended for 3 months. But that's our greatest worry is if the staff are removed, that we're going to be quite vulnerable to if we start seeing large numbers of sick patients coming in for a third wave.
Yeah. Have you vaccinated, and what are your thoughts about the different vaccination conversations going on, the slow speed in terms of the rollout or the efficacy of these vaccines, and which vaccines for you are the most efficient?
I have vaccinated. Thanks. Our staff at our hospitals, I work at 2 hospitals at Cecilia Makawani. They've got vaccination sites running at both. It has been quite slow. I think the supply of the Johnson & Johnson through this trial, this phase 3 trial, has been sort of coming in pieces every week. At the moment, we've vaccinated most of our hospital staff, which is reassuring that at least staff are protected. In terms of what the numbers of vaccination that we're needing to get to, we're way too slow, and this is really the greatest fear, and that I think I'll sleep a lot better once phase 2 is done. Once we've vaccinated our elderly and our patients with comorbidities and our other emergency staff, they're the greatest risk of severe disease and death. So I think hopefully once we've got phase 2 vaccinated, that the country may be able to, ease up some other restrictions. In terms of, it's a complex debate in terms of the pros and cons of the different vaccines. I think the Johnson & Johnson, a great advantage is that it's a single dose, which from a practical level, halves the amount of work and makes it a lot easier. We're very fortunate that South Africa's, that we've got a well-developed vaccination research, and expertise, and that some of these vaccines, Johnson & Johnson and AstraZeneca, were actually trialled in South Africa and trialled against our new variants. So that was a huge advantage. We would have been in the dark as to the concerns about AstraZeneca not working well against the 501 variants. So we've got evidence that the Johnson & Johnson does seem to be reasonably effective against that variant, and hopefully more data will be coming out on others. I think the key thing, it's great that Aspen and PE is going to be started manufacturing Johnson & Johnson, as I understand, and it sounds like they should be able to produce enough per day that we can actually vaccinate. So I think the key limiting step is actually going to be coordination, vaccination sites, accessing the right members of the population, the elderly and those with comorbidities, and getting them vaccinated as fast as possible. And that this is the clock is ticking while we're in low levels of infections for getting our vulnerable population vaccinated. So we're still in phase 1, completing the healthcare worker vaccinations. I think we're on 250,000, and they were talking about over 1 million. So we've still got a fair way to go of fair numbers of healthcare workers that still need to be vaccinated. But then the numbers are going to have to ramp up a lot for phase 2 to be reaching. I think it's something in the region of 5 million that are elderly or even more than that, elderly and vulnerable.
Let's thank you for your thoughts and your time this morning.
It's a pleasure.
Thank you so much, Dr. David Stead, an infectious diseases specialist at Frere Hospital in the Eastern Cape.